job today is to talk about IgA nephropathy. I thought I would choose a case which is what we do see in hospitals, not infrequently. For instance, there's a patient who's currently in CCU who's currently admitted for other stuff, but this person has IgA nephropathy, and I got a question from the resident last week. So we're going to go through a case that I recently saw, as well as some updates about IgA nephropathy. If I was to do some take-home points for trainees in the room, it'd be first of all that the dipstick is very easy and it's very useful, and you can get a lot of information within 1 minute, which is almost unheard of in the realms of general medicine. It'd be good if you were able to convert the urine protein to creatinine ratios to milligrams of protein a day, because if you think about things like nephrotic range proteinuria, then they say 3.5 grams of protein each day. Well, what is that converted into a UPCR? Because that's actually what we use. And finally, my take-home point would be the SGLT2 inhibitors. They're ready for prime time. It's quite an exciting time over the past couple of years, the innovations within CKD and IgA. So this is the case that I've got. He is a 34-year-old gentleman who essentially came with issues of proteinuria, hematuria, and kidney injury. Now, he actually went up to ED with 1 week of ERTI symptoms. So, he had sinus congestion, he had a runny nose, he had a productive green cough. But then about day 6 of this syndrome, he then noticed that his urine was really dark. And so that's what actually brought him over to ED. When he was in ED, they did some basic blood tests, and they found that his creatinine had risen from 116 up to 162 micromoles per litre. With regards to his past history, he was diagnosed with hypertension in 2017, and this was in the context of around the time where he got his gastric sleeve. At that stage, his BMI would have been about the 40-somethings, and he was about 160 kilos at that stage. Since having that gastric sleeve 5 years ago at that stage, he'd lost about 30 kilos, so he was about 130 kilos. He'd also had a left knee reconstruction. There wasn't any sort of history of any sort of diabetes or NSAID use. There wasn't any night sweats or hemoptysis or inflammatory arthritis kind of symptoms. He didn't have any kidney stones or any sort of pyelonephritis in the past, and there wasn't any family history of kidney disease either. With regards to his social history, he was a current smoker of 10 pack years, and he was trying to cut that down. On examination, his blood pressure was 150 on 100. He had a low-grade temperature. His BMI was 38. And he was largely euvolemic. There wasn't any sort of rash or any sort of flank pain. His chest sounded clear, and his heart sounds were normal. So this was the dipstick that he had. And so this is a table of the probability that someone has greater than 500 milligrams of protein in their urine. So the black numbers are the specific gravity of the urine, and along the y-axis is what you get when you do the dipstick and you get you're trying to do it manually. So you got 0 up to 3+. So this person had large blood in his urine. His specific gravity was 1.025, so that's here, and he had 2+ of protein. So he fits in this line here. So if you kind of do the table, there's a 71% chance that he's got significant proteinuria greater than 500 milligrams per day. And then you pair that with renal dysfunction, and then you pair that with blood in the urine, and then you know that this person has some nephrological diagnosis underlying, most likely.
If I want to find that table, does that have a name? If I Google it or something?
I can send you the table. So these were his basic blood tests. I'll just give you a minute just to have a look-see. So the salient features really is that his creatinine is elevated at 162, which gives an EGFR of 47. And so this was November was actually the time that we met. But if you look back at some of his bloods, even in January, his creatinine was elevated at 113, his EGFR was 73. And for someone who's in their 30s, that's not potentially normal at that stage. His hemoglobin was normal / slightly elevated, in keeping with someone who smokes. and his albumin of note was normal. So these were the differential diagnoses that I had at that stage. My first one was infection-related glomerulonephritis. And the reason why I thought this is, usually with IgA nephropathy, it's said to be a synpharyngitic hematuria. So at the time that they get their ERT symptoms, then within 24 hours, then that's when they're starting to get blood in their urine. Whereas this person was day 5, day 6 of their illness, and it's only started then. So potentially it could be the infection-related glomerulonephritis. The other possibilities, of course, was IgA nephropathy. And the reason why I thought this was it didn't sound like this person had a normal kidney function to begin with, because even 10 months ago, he was a little bit off, his creatinine was slightly elevated. Other possibilities included FSGS. He had an elevated BMI and smoking, and essentially what that does is it puts pressure onto the kidneys and causes some protein, but it doesn't necessarily explain why he had macroscopic hematuria. And lupus, because if you've ever watched House, then that's always a differential diagnosis. So if you got that far to the differential diagnosis, then I think that's as far as you need to go, because you've got that information that, okay, I need to call the renal team for that, right? So then this is our role. When you find someone who's got big protein in their urine, blood in there, plus an abnormal renal function. So that's when you call us. And then so I sent him for a further screen. So these are his investigations. I'll just give a run in a minute. So of note, what we can see is that his urine protein to creatinine was 188. So if you want to try to convert that to milligrams of protein a day, you essentially just added 0 to the end of it, right? So it's 188, then you add a 0, so that's 1880 milligrams of protein a day, right? That's just a rough kind of rule of thumb. And that fits in with the urinalysis, which is 3 plus protein, which indicates a high probability of greater than 500 milligrams of protein, and that all fits together quite nicely, right? He had some white blood cells in his urine, and he had red blood cells, which is unsurprising and confirmed on his dipstick. Interestingly, his infective screen was borderline high, so his anti-streptolysin O titers were 200, which is the upper limit of normal, and his anti-DNase B was also on the higher side as well. And bear in mind that these usually take a few weeks to actually spike up, so week 1, they're already a bit elevated. His Hep B, Hep C, and HIV were negative. He had an autoimmune screen, which was all normal, and he had a myeloma screen, which was negative. So this kind of picture then made me think potentially it could be something like infection-related GN, right? Because you've got elevated strep antibodies. But the only way really that you know what the diagnosis is if you do a kidney biopsy. And so this is what we got. So on the right side is a normal biopsy, and what I just want, and this is his biopsy on the left. I just want you to have a look at, the matrix, which is the bits in between the glomerular capillaries, which you can see are quite wide open. So you can see open, 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 open. There's a little bit of matrix in between, but there's a lot of wide open space there. If you look at his glomerulus, so this is it here, and there is some open capillaries around the place, but you can see this bit here, I've just marked it out, has got a lot of matrix deposition there. I hope you can see that. So this is an element of sclerosis there, which means some scarring in there. So of the biopsy sample which they took, there were 20 glomeruli, and 8 of them were actually sclerosed completely, and a further 3 had these kind of changes in there. So this implies that there's some degree of chronicity, which is in keeping with his creatinine, which was elevated 10 months ago, right? Because scar takes some time to develop. This is another picture. Again, normal on the right, and on the here's on the left. And this time, what I want you to focus on are the mesangial cells, which are these blue dots here. So usually there should be about 3, maximum 3 of these blue dots between the capillaries. And if you look at his, you can see that there's 1, 2, 3, 4, 5 in this kind of patch, 1, 2, 3, 4, 5 kind of in this patch, and so there's increased mesangial hypercellularity within this biopsy. After that, what you can do is you can have a look at you can zoom out of the whole sample. You can see what does this sample look like and how much scar tissue there is. So this is the trichrome stain. And so the blue bits are the scarred up bits and the red bits are the normal bits. So if you kind of have a look at the whole thing, maybe about 40% of that whole tissue was scarred up. Again, suggesting that there's signs of chronicity that's there. After you do the light microscopy, which are those things I showed you, you can also stain it for immunoglobulins. And so here's one lit up for IgA nephropathy. Oh, sorry, IgA heavy staining. There were a couple others, but IgA was the main thing. Finally, what you can do is you can the electron microscopy. So you zoom right in onto the glomerulus and the basement membrane, and you have a look inside the actual tissues of the supporting structures. So on the right side, this is the normal side. I appreciate that it just looks like a lot of grey blobs, but just bear with me here. So this is the mesangial cell here, right? And then around it, there's just some supporting matrix there, and then you can see the glomerular basement membrane there, and those finger-like projections that come out. So those are the foot processes, and so that means that where the foot processes are, that's the urinary space, right? So between here and here is the urinary space inside there. This is your capillary, right? So the blood flows through there, and then the fluid goes through that and into the urine space. Another way that you know that this is the capillary is you've got this big blotchy black thing, which is your red blood cell. Okay? So if you look on this side, I think this is probably the capillary because this is a red blood cell. Okay, and these are probably the mesangial cells. Okay, but then look at all this junk that's in there. So all these dark patches here. So that's all the deposition of IgA. So going back to the differential diagnoses, I had IgA, I had infection-related GN first up, based on the elevated ASOT and the anti-DNase B titers. But actually, if you believe me with the biopsy, those biopsy features are not concordant with that at all. And biopsy features are all concordant with IgA nephropathy, as well as some scarring as well. So that's actually the diagnosis here. It's actually IgA. And plus minus there's some FSGS, which is those segmental scarring that you could see on the glomeruli, and maybe that's secondary to either the IgA.
Oh, sorry, I was just going to say, so does that mean that the reason that his titer was strep titers were up was because he had that, he coincidentally had a strep throat and happened to be at the same time? Or can you see that in people that those titers will be something like that?
Well, I think that we measure ASOT, aside from this indication of other major things related to that, we measure ASOT, and then we find that in young people that it's not, that the movement of that titer over time is quite heterogeneous, and so it could be that he has to for months ago going their way back down. It just means, I think that number, as Jen was saying, that number being below cutoff is kind of neither here nor there. It could be it's on its way up, it could be it's on its way down. And in fact, where there's diagnostic it's according to it's a very non-specific marker. That's why you don't kind of come to the doctor with pharyngitis and get that blood test.
Yeah. And so there was also some FSGS, either whether or not that's because of the IgA or whether or not because of the elevated BMI, or whether or not it's because of your smoking status. So that was the diagnosis. I forgot to say earlier, if you have any questions, then you can go to this website, menti.com. If you punch in the code there, then you can ask questions in a de-identified manner as well. So that was my conclusion. He had IgA nephropathy and plus minus some FSGS. So what I did was we put him on prunapril, an ACE inhibitor, which is a nephrologist's best friend. I asked him to stop smoking, and he was also going to work on the weight loss too. So if we talk about IgA as a disease going through, the epidemiology is a little bit here and there. of those who get end-stage kidney disease, glomerulonephritis is number 2 cause of end-stage kidney disease, and of that, IgA is the top of the list. So it's not something that's very uncommon, and you'll likely come across it whether or not you work in ED or on the wards. The epidemiology goes between 2.5 per 100,000 up to 1.6%, so it's quite variable, and probably that just has to do with the screening practices that are in play. For example, in Japan, it's mandated that those school-age kids and also adults working get a urinalysis each day, so they actually pick up quite a fair bit, and they're also quite aggressive with their biopsies as well, so they can nail that diagnosis of IgA. For us, if someone has a bit of blood in their urine, but the protein of that isn't all that much, then you won't go biopsy, and therefore you might not make that diagnosis. There are primary and secondary causes. So the primary is we don't really know why this happens, and the secondary causes are non-specific, but especially people with liver disease, and maybe that's because they're not clearing that abnormal antibody that we'll go through in just a sec, and especially Hep B can be associated with some autoimmunity like sarcoid as well, and also cancers like lung cancers too. If we talk about the pathogenesis, essentially it's the IgA1, subtype 1 antibody that the patient has. And you might hear something to do with the hinge region, which is essentially where they branch off. So essentially what happens is the hinge region lacks a galactose molecule. And so because of that, it turns into an autoantigen. So the body sees this whole antibody and goes, actually, that's abnormal. And then it starts to create IgG antibodies against that. And then that complex forms together and then, for whatever reason, gets deposited into the kidneys, into the mesangium, etc. Now, we do know that there is some hereditary component to that, because those relatives of people with IgA nephropathy, they can also have, they're also at risk of having increased abnormal IgA1 circulating antibodies, but they don't necessarily develop the disease as such. So we don't exactly know what actually triggers it from a disease to just a abnormality that just is there. So there are a few presentations that patients can come with. So many of them come with their synpharyngitic hematuria that we discussed, and usually the dark brown urine kind of gets better after about a week or so after the infection has passed. Those people tend to go into remission quite well. This compares with the patient who comes with constant asymptomatic microhematuria and proteinuria, which is the other big category in about 30 to 40% of cases. So that means that they've always got a level of blood in the urine, so if you dipstick it, it's there, and they've also got protein there as well. And they might not present every time they get sick, they might have the dark brown urine. You can get nephrotic syndrome, but it's quite rare, so that's in less than 5% of cases. And I guess that's why they fit the IgA in the nephritic kind of picture. And rarely, if it's really severe disease, then it can cause florid renal failure, especially if you get crescents on top. But that's, again, less than 5% of cases. So just going back to the dipstick, because I think this is quite important. So we looked at the specific gravity, and we looked at the percent at the what you get on your dipstick, the percent of chance that someone has got greater than 500 milligrams of protein in their urine. So you'll notice that if the urine is very dilute, 1.005, then but you've still got some protein there, then their chance of having heavy proteinuria is quite enhanced. Whereas if the protein is really concentrated and there's only a bit of protein there, then their chance is relatively low. But regardless of whatever the case, if you've got a protein of 3+ in your urine, then you're looking at something nephrological. Blood can influence this, can be a confounder for this, but it shouldn't be that much. So if you've got some blood in it, then you might get an extra plus in your urine, but it shouldn't influence it that much. If we look at the biopsy for someone with IgA nephropathy, so this is an image that I pulled from Google, and hopefully this is a bit more obvious where you get those patches of the IgA deposition there, which are quite the solid pink. And then I don't know if you can magic eye it now looking at our patients, but maybe you can see that that's kind of starting to develop. This is the electron microscopy of someone with IgA nephropathy. On this right side is a textbook picture. So these are the dense black grey bits, and then this compares with our dense grey bits there. Okay. So after you do the biopsy, then you can move on to staging, because the biopsy plays a big role in how severe someone's IgA nephropathy has. So the mesangial hypercellularity we looked at, so that was the number of those cells clustered together. So the more you have, then the worse the prognosis. You can also look to see if there's other cells within the capillaries as well, because that's a sign of activity, as are crescents as well. And then you can look at the chronicity of the disease as well. So if you looking at segments of the glomerulus which is all scuffed up, then that shows it's been going on for a little while. And if you show that someone, if you zoom out and looking at those blue areas that we saw of this patient sample, which was about 30 to 40%, then they also have a worse prognosis as well. So overall, after 20 years, about a quarter of patients will have end-stage kidney disease. And the red flags for patients that are at risk of progression include those with the blood pressure greater than 140 on 90, if they've got proteinuria greater than a gram per day, if they've got already renal impairment at the time of diagnosis, so that means creatinine greater than 120, if they've got interstitial fibrosis, which is what our patient had, if they've got elevated BMI, which is what our patient had at 38, and if they're a current smoker. So if you're a smoker, then it increases your risk of end-stage kidney disease by a factor of 10. And so you can plug all those things in, the age, the EGFR, you can plug in their scoring together in a calculator, and you can predict what their chance of end-stage kidney failure is in about 5 to 10 years or so. So this is a slide which shows the risk of progression given the amount of protein in the urine. So this is along the x-axis is years, and along the y-axis is if they get end-stage kidney disease or not. And so if we think about the worst-case scenario, which is if they've got a protein in their urine of greater than 3 grams per day, and if you work backwards, that's 3,000 milligrams. Therefore, if you then pop off of 0, then that's a UPCR of 300. Then their prognosis after about 10 years, they're going to probably end up on dialysis in about 60% of cases, right? And this compares with someone who has minimal protein. So if we take, say, less than a gram, which is almost the same as less than 0.3 grams, then their prognosis in about 90%, over 90% of cases, they'll be okay. So you can see from this slide why we're so concentrated on controlling the protein. So what are different ways to do this? So just as a big overview, what we do is try to control the protein, and if we still have trouble with that, greater than a gram, because that's still bad prognosis, then we will consider enrollment into a trial. And we consider trial if they've actually got kidney to save, right? So if the EGFR is already less than 30, then there's not really much kidney to save. So I had a question about this patient last week whose EGFR was 17, 18, and if there was anything further to optimise the kidneys, and unfortunately, the ship has sailed on that one. By contrast, if the EGFR is greater than 30, then you might consider doing some steroids. So we'll just go through some of the data. So the first thing that I want to talk about is the supportive management. ACEs and ARBs are commonly used for us, so I don't want to go through the data necessarily for that. And they can be used for hypertension control, which again is one of the risk factors for progression of disease, as is metabolic syndrome and smoking. Fish oil is an interesting one. So if you take about 4 to 6 fish oil tablets a day, there is a thought that maybe it decreases the risk of progression of IgA, and the thought is that it decreases your cytokine production and the inflammation, and therefore it protects it that way. But the evidence is neither here nor there, but we don't discourage it if someone wants to do it because there's not that many side effects apart from flatulence. The big thing that I just wanted to mention is the SGLT2 inhibitors, which are the flozins. So this is a study from DAPA-CKD. So this was published 3 years ago, and it was a multi-center, double-blinded, placebo-controlled RCT, and it covered 21 countries. And so the mechanism of the SGLT2 inhibitors is that it regulates the sodium handling of the nephron such that it increases the flow of sodium to be excreted. And by doing that, therefore you decrease the pressure going into the kidney. And if you drop the pressure going into the kidney, then also you protect the kidney, and therefore you decrease their proteinuria. It also has other effects as well, so it drops people's blood pressures by about 5 millimeters of mercury, and there's also an additional weight loss benefit as well. So it's probably multifactorial the way that this medication works. So this particular study, they enrolled those with an EGFR of between 25 and 75, and a UACR of greater than 23, right? So that's about 200 milligrams of albuminuria. They had to be RAS blockaded for at least a month before they started, and they couldn't have had any sort of immunosuppression leading up for it. And so their head-to-head was dapagliflozin 10 milligram, which is the normal dose, versus placebo, and so that just means standard care, which is things like ACE, ARB, fish oil, what have you. And so the outcome was a 50% drop in the EGFR, end-stage kidney disease, death from kidney disease, or death from cardiovascular outcome. And the graph that I've shown here is the renal endpoint. So that's the drop in the EGFRs or reaching end-stage kidney disease. And you can see they got about 270 total, about 130, 140 in 130 people in each group, and they followed up for a mean of about 24 months. And you can see that at this stage, at 24 months, maybe about 5% of those on the dapagliflozin group got that renal endpoint, whereas this compares with about 18% of those on the placebo arm. So if you did a hazard ratio of 0.23, that means that on average, at any point in time, the risk of one of the endpoints of the end-stage kidney disease drop in EGFR was about 23% chance of those taking placebo. So it's quite a significant improvement. Does it apply to our patient? Look, it's always very difficult to generalise. With this particular study, their mean age was about 51, their EGFR was about 44, and their UACR was 90. Bearing in mind that our patient was in his 30s, his EGFR was about 60, and his UPCR was about 200. But potentially, the more protein you have, then the more you have to gain. So not only did this study work for the outcome, but also decreased the proteinuria as well. It decreased the blood pressure by about 3 to 4 millimeters of mercury. And it worked in all the strata. So whether or not you're diabetic, non-diabetic, whether or not your EGFR was less than 45, or greater than 45, or whether or not the urine protein to creatinine ratio was low or high, it worked in all those strata. So it's a pretty good study. And so this was prematurely terminated due to efficacy. We always have to think about adverse events, and in this particular study there weren't that many. So the theoretical risks of SGLT2s are hypoglycemia and also ketoacidosis, because as you're urinating out the sugar, then the body will try to burn other stuff, which are your fats, and therefore cause ketoacidosis, and they didn't find that this happened in the study. They also didn't have any genital mycoses, which is the big thing, infection risk of SGLT2 inhibitors, and that's especially in those with diabetes. UTIs are said to be one of the risks of SGLT2s, but it's not really that high necessarily. It's actually the genital mycoses, and they didn't find that they had anyone like that either. So this is probably the biggest study of IgA nephropathy for this particular drug, of this particular drug. And it's also been repeatable as well. So there was this trial that came out 2 months ago called EMPA Kidney, and they didn't focus necessarily specifically on IgA, but they took CKD as a cohort and they did a similar thing, and again, similar results. They included those with IgA nephropathy, of course, but they haven't actually stratified it as yet. I'm sure the data will be outcoming in the next few months. So that's really your best supportive care kind of arm. And then I guess you've got to think about if someone is worth giving some steroids to. And so this is the data on immunosuppression. And the reason why I put this out here is for the registrars, for the BPTs, they might ask you about this because it was coordinated by the George Institute. So this was a double-blinded placebo-controlled RCT, and they took a similar kind of criteria for patients, so EGFR greater than 20, and the 24-hour proteinuria of greater than a gram, so those high-risk patients. And they used methylpred, and converting that over to prednisone, essentially they said you could have about a milligram per kilo of prednisone per day up to about 60 milligrams, just roughly converted. It is important to note that they then had to drop the dose a couple of years later because they found that on that higher dose people were actually dying from infection. So that's why the results are a little bit mixed up. But essentially, there were a few who got up to 60 milligrams per day, and there were a few who got up to, say, about 40 to 45 milligrams of prednisone per day. So it was that, the methylpred versus placebo, which is just the best supportive care. And their outcomes were 40% decrease in their EGFR. It was end-stage kidney disease or death from end-stage kidney disease. So they ended up enrolling 500 people. Their mean age was 40 with a mean EGFR of 62, and their mean proteinuria was about 2.5 grams. And so if you look at their graph here, you can see about 5 years or so, the risk of one of the primary outpoints was about 20-something% in those on the steroid arm, and about 40-something% in those with the placebo arm. And so that was also replicated if you're talking about pure kidney failure as well. It was lower in the pred arm, in the methylpred arm than in the placebo arm. The amount of proteinuria came down as well, so it was 1.7 grams at the end of the day with the steroid arm, and 2.4 grams on the placebo arm.
So they're staying on things like 60 milligrams of prednisone for that period of time, where that the only remaining steroids for those.
Yeah. So they started at about 60 milligrams, and then over each month they went down by about 10 milligrams equivalent. So that by that month 9, it was finished. Yeah. So when we're talking about, sure, it worked. But there were a few people that died. So there were 7% who need to be hospitalised for whatever, whether or not it's cryptococcal, BCP, UTIs, or respiratory infections, and 4 of them actually died. So that's why they actually did a second arm later, which was the lower dose. And then on the second arm, then they got BCP prophylaxis with some Bactrim at that stage. So this trial worked. But it's hard to actually compare it because there was another trial done in Germany a few years earlier, which actually showed no benefit of steroids. And so I'm not sure if we actually know how to use steroids properly in these patients. And so that's why clinical trial is probably actually the second line after best supportive care. One of the innovative ways which you can actually decrease your steroid systemic exposure is by trying to target the mucosal patches, because the mucosal patches are said to be the places where IgA kind of develops. So in the pious patches. So there are some trials at the moment which is where patients are getting budesonide oral, and so it's getting released in those pious patches there. In Japan, the other thing that they do is they do tonsillectomies as well. The data for that is a little bit weak, so therefore in Western countries, we won't see that actually happen. If we're talking about recurrence, it's about 50% risk of recurrence. However, it hardly ever causes graft failure, so their outcomes are actually very similar. So we might only pick it up again, similarly, because we do, for example, at Westmead, we do protocol biopsies at the 1 year mark. You might see that there's some IgA there, but it doesn't cause any damage usually. So this is where I'm at with this particular patient. We're at month 2 at the moment, so on the high dose of the perindopril, his blood pressure is now 125 on 80. His creatinine's 125, which gives him an EGFR of 63. He has started to take varenicline or Champix for his smoking cessation, and I'm planning on seeing him in the next few weeks and maybe add on some dapagliflozin. So that's it for today. So today we talked about IgA nephropathy. We went through a case of a young gentleman who's only recently diagnosed with IgA nephropathy. based on proteinuria, hematuria, and abnormal renal function. And the biopsy was really useful to actually differentiate that compared with infection-related GN. Even before you get to that stage, if you're able to do the dipstick and you find that they've got blood protein abnormal renal function, then you're doing well, and you can see how it's quite an easy test to do. We've talked about converting the urine protein creatinine ratios to milligrams of protein a day, so just adding on a 0, so that the urine protein creatinine ratio of 100 is about 1,000 milligrams of protein a day. And we've gone through some of the data of SGLT2 inhibitors, which are, I believe, ready for prime-time use in IgA nephropathy, but also probably CKD as well, but more data to follow. So thank you for listening. Do you have any questions? Jake.
What's a good, practical approach to someone having proteinuria on a dipstick in the absence of, say, known diabetes? At what level do you think we should routinely quantify in hospital with secondary measurements, and where do you think we should considering cells or also managing it ongoing? Is there a cutoff that we should be worried about currently, or is there a kind of level we should just say, well, that's all?
Yeah. In hospital setting, unless they're nephrotic syndrome, then there's no urgency necessarily. There is no strict cutoff for proteinuria, so diabetics often have proteinuria. I've seen up to about 10 grams a day. So when you consider a secondary screen is if there's something that's clinically suspicious. So say if someone has had diabetes for 10, 15 years and it's got all the other complications of diabetes, then I think it's safe to go down to that diagnosis. However, if they've only had it for, say, 2 years without any end organ damage, but they've got significant proteinuria, then that's when it triggers us to think about, should we be looking harder? Ultimately, your diagnosis is based on your biopsy, and so in about 10% of cases which are suspected to have been diabetes, they've actually changed the diagnosis because exactly of that reason, and you find something else that we didn't suspect. So yeah.
So we normally had the table and we had the 3+ of protein, and you were talking about 500 milligrams a day.
Yep.
Is more than 500 milligrams a day, that's the cutoff of abnormal protein a day? Or, if you're talking about the nephrotic range versus the frequent one, what's that sort of in between, or more than 500 milligrams?
Yeah.
You don't need it less than that. Can be more?
Well, I suppose what I would say is over 500 milligrams should trigger the referral over to nephrologist.
So really, if you're getting 3+ protein, you should be quantifying it.
Yeah. Whether or not that's an inpatient setting or whether or not that's an outpatient setting, that's fine. Like for instance, if someone has acute tubular necrosis, you might actually get 3+ of protein because it just sloughs off. That might be just temporary. Right, so we have to take it into context. But certainly, I guess my point is, if it's 3+, there is a high likelihood, and marrying it together with a clinical story and blood, that's real, that's undergoing. No questions online. Great, thank you very much.